So it's my pleasure to be moderating the next session, which is the wind-up of the African site isomers and then also the New World isomers. And so we'll start with the East African isomer, and I'll invite Grant Dorsey from UCSF to present on that. So, is he around?
Just touch something. Ah, there we go. Well, first I'd like to thank the organizers for inviting me out here. I am representing the East African isomer. We call ourselves PRISM. I did not think, I am no Bill Moss, so I did not think it was possible to try to summarize all the work we do in 25 minutes. So I thought I'd tell us kind of a focused story about one topic that is contemporary and has a real public health kind of bend to it, and this is school public health. So I'm going to talk about the impact of vector control interventions under operational settings in Uganda. And I'll start with a little background. Every good story has some background. So the reality is that really we have two main interventions for vector control to prevent malaria in sub-Saharan Africa, and that's long-lasting insecticide-treated bed nets and indoor residual spraying of insecticide, which has been mentioned in the previous talks. Just a little kind of quick, simple comparing contrast. So for LLINs or ITNs, there's a really excellent evidence base with many cluster randomized trials showing that they're very effective. They reduce morbidity by about 50% and all-cause mortality in children by about 20%. And there's really not much of a debate about their efficacy, at least at the time when these trials were done. Now, it's been almost 20 years since the last trial was done. In fact, it would probably not be ethical to do a trial of bed nets versus no bed net, but that's where we are. IRS, although there's a lot of historical evidence and a lot of observational data showing that it can be quite effective, there's relatively limited data for controlled trials. So probably we have less of a knowledge about the quantitative impact of IRS. Just some practical issues. One of the reasons bed nets are so attractive is they're relatively inexpensive. They can last up to 5 years, and they're relatively easy to distribute. In contrast, IRS is quite expensive, and it also depends on which formulation insecticide you're using. It can get really expensive. It has to be repeated every 6 to 12 months generally, and it can be really logistically challenging to implement. One limitation of bed nets is we're only currently able to incorporate one class of insecticides into bed nets. That's the pyrethroids, and there's been a lot of talk about pyrethroid resistance, and I'm going to talk a little bit more about that. Advantage of IRS is we can use any of the 4 major classes of insecticide. And just to talk about kind of where we at with coverage, this is from the 2015 World Malaria Report. Bed net coverage has really been scaled up fairly dramatically across sub-Saharan Africa. It's estimated now that about 2/3 of the population have access to a bed net, and over half of people are sleeping under a bed net, while IRS, still less than 5% of people at risk in Africa are protected by IRS. This is data from a recent publication, high-profile publication from Nature, from the Malaria Atlas group, which used a modeling approach from mostly cross-sectional surveys of parasitemia, almost 30,000 cross-sectional surveys, to try to get an idea of kind of what's happening with the burden of malaria in sub-Saharan Africa. And they estimated that there's been a fairly dramatic decrease of 40% between 2000 and 2015 of clinical cases of malaria. And then they tried to, estimate what proportion of these cases averted was due to different interventions. And their conclusion, this graph shows cumulative cases averted over time. So by 2015, they estimate that almost 700 million cases of malaria had been averted by these interventions, and that bed nets were responsible for a majority of those, 68% of cases averted. IRS, a smaller proportion, and the remainder ACTs. So really, there's a lot of evidence. There's a lot of messaging out there that bed nets are really great, and we really need to scale them up, and they can make a big difference. And there's really kind of, in a lot of policy forums in Africa, is this kind of one-size-fit-all approach to like what we should be doing to control malaria. I also just wanted to mention, because there's been a few recent studies that are interesting looking at whether there's advantage of adding IRS to ITNs, and maybe surprisingly, the results are somewhat mixed. And indeed, the first two studies, which were conducted in West Africa, where you have reasonably high coverage levels of ITNs and low pyrethroid resistance. One study in Benin used a carbamate for IRS. The study in Gambia used DDT, and they did not show any benefit of adding IRS to bed nets. While a study in Tanzania, which had modest ITN coverage and a lot of pyrethroid resistance and used a carbamate for IRS, there was a significant benefit of adding IRS. So this is still a controversial thing about how we should be using these interventions in combination, or whether we should use them in combination. Now just to move to Uganda, and like a lot of African countries, Uganda has really made tremendous progress in scaling up ITNs. There have been a number of kind of subnational campaigns between 2006 and 2011 that increased coverage from 16% of houses that had at least one ITN up to 60%. And then between 2013 and 2014, over about a one-year period, Uganda implemented a universal bed net distribution campaign where they literally gave out bed nets for the entire country, 22 million nets for 35 million people. And in a survey that was done shortly after this campaign was done, they documented over 90% of households had access to a long-lasting bed net. And the number of nets per person also increased very dramatically. So in 2009, it was about 0.8 nets per person, and by 2014, it was 2.5. So not only are more houses getting nets, but the number of nets per house has really increased. So, there a lot of, this is a big success, and Uganda got a lot of, appropriately, attention for the success of this program. IRS, the program, Uganda had used IRS in the 1950s and 60s with some historical success, but then over a 40-year period, it was really abandoned. And then, mostly because of funding from PMI, they restarted the program in around 2008. And they started by focusing on 10 districts in the northern part of the country. So there's about 100 districts in Uganda, so this is about 10% of the country. This is an area which historically has very high transmission intensity. They initially started with pyrethroids, but then realized that that was probably not a good idea, and I'll show a little data on that. But, and they switched to a carbamate, and they've continued this program for 4 to 5 years. And then in 2014, they made a decision that they needed to kind of share the wealth. So they didn't have enough funding to expand the program, really. So what they decided to do is stop IRS in these 10 districts and then move it to 14 districts in the central and eastern part of the country. And that was purely just a matter of resource availability. Although the thought was that because they gave out all these bed nets at the end of 2014, that gains made by the 5 years of IRS would be able to be maintained. I mean, actually, the idea is that they would spray parts of the country for 4 or 5 years, then get it down, move to another part, and just keep rotating around the country until eventually the whole country's down. And so that was the kind of thought process. Very complicated thought process. So now I'm going to talk about kind of 2 projects we have ongoing with our ICMR. The first one is estimating the impact of ITNs and IRS at 3 sites that have varying transmission intensity. So in our ICMR, the goal of this was to estimate the impact of these population-level malaria control interventions. So I think, as Peter asked a question earlier, we're not allowed to do interventions in our ICMRs, but we can observe what happens when the government does stuff. So we have set up these comprehensive surveillance program in 3 different sites, and we looked at the impact of these interventions over a 5-year period. So our 3 sites are is this working? Oh, sorry. I don't know. Oh, here it is. Yeah. So our first site is Wallakuba. It has a relatively low transmission setting for us. It's low, EIR about 3. It's a peri-urban site. It's kind of interesting. When we originally chose it, we thought it was pretty rural, but it's kind of been, had some, I guess, urban sprawl, you'd say. So it's become kind of peri-urban now. The second site in the, can't get this to, here it is. In the southwest part of the country, Chihihi, has an EIR about 30. And then in the eastern part of the country, Nagangara, is our high transmission site, a rural site near the border with Kenya with an EIR of 300, over 300. So almost 1 infected bite per person per year. It's pretty remarkable. So, and this is just when the interventions were implemented. So all of these sites got their bed nets, the universal ITN distribution over a 1-month period. In Wallakuba and Nagangara, it was in November of 2013, and Chihihi in June of 2014. I'm not going to present this data, but we have other data from cross-sectional surveys done documenting that the coverage was very high, and it really dramatically increased after this. IRS was only done in one of the 3 sites. This is, Nagangara was one of these new, one of the 14 new districts that got chosen in the kind of second phase of the IRS program, and that started in December 2014. And the plan is to use a carbamate every 6 months for 3 years. They say they have funding to do this for 3 years. Our surveillance methods, we collected data using different methodology to monitor trends over time in the malaria burden. So at all 3 sites, we have health facility data. So this is data from health facility. I'm presenting data just from children from 6 months to 10 years of age who present to the outpatient department with suspected malaria and are tested for malaria. And our main indicator is called the test positivity rate. So simply the numerator is the number of children that tested positive for malaria, and the denominator is the number that were tested. But this is among symptomatic cases. This is different from a parasite prevalence measure. We also, this is a ton of work summarized in one row in a table, but we set up these cohorts that were randomly selected from the community where we enrolled all children between 6 months and 10 years from 100 houses in each community. And we've been following using both passive and active surveillance for all their healthcare needs 7 days a week. And the primary metric is for this surveillance method is the incidence of malaria, simply the number of laboratory confirmed cases of malaria per person year. That's a very difficult metric to actually accurately measure. And then we're also doing entomologic surveys actually in the same 100 houses per site where we're doing the cohort studies. And once a month we collect mosquitoes using CDC light traps. And the primary metric here is the daily human biting rates, so just the number of female Anopheles mosquitoes we catch per house per night. So this is, I'm going to present data from each site separately. This is a pretty busy slide, so I'll try to kind of walk you through it. So the x-axis is just time. So it's starting in January 2010 through November 2015. And then there's 3 y-axes. So the green line is the test positivity rate. So it ranges anywhere from 0 to 80%. The red is the incidence of malaria. So in this graph, it's anywhere from 0 to 1 episode per person per year. And then the blue line is a daily human biting rate, which ranges anywhere from 0 to 6 mosquitoes per house per night. So interestingly, and then this, this vertical bar in gray is when they gave out bed nets. So this is kind of the intervention of interest. So interestingly, it looks like the burden of malaria is actually going down before they gave out the bed nets. It started in around 2011. I don't have time to go into this, but we think that part of this may be due to just development, that there was just urbanization of these sites, and we think that might have contributed to it. But anyways, just using time series analysis, controlling for rainfall and seasonality and other factors, we estimated that there was no change in the test positivity rate after the ITNs were distributed. We did see a signal for a lower incidence of malaria, although it seems to have waned over time. And in fact, this trend's kind of continued where malaria is kind of going back up again in this calendar year. And then the human biting rate actually went up after the ITNs were distributed. So that was in Wallakuba. In Chihihi, our median transmission site, basically we saw no change, really, in any of our clinical indicators after the ITNs were distributed. And then in Nagangara, our high transmission site, after the bed nets were given out, again, we saw no change. In fact, we saw an increase in the incidence of malaria after the ITNs were given out in our time series analysis. But when IRS was implemented, so the black vertical bars this is the first round, the second round of IRS, we saw rather dramatic decreases. The test positivity rate went down by almost 25%, the incidence of malaria by 75%, and the human body rate by about 25%. And that probably is conservative because the time series analysis is basically modeling kind of slopes or the trends. But you can see that by the time, by November of last year, and again, these trends have continued, so the incidence of malaria, we used to see kids get malaria 3 to 5 times a year, and now we're seeing 0.3 episodes of malaria per year, so almost a 10-fold decrease in the incidence of malaria, and a similar decrease in the test positivity rate. So really dramatic. For those of us who worked in this area a long time, it's been just striking. We used to, a practical way to say this is our cohort of 300 kids, we typically see 100 cases of malaria a month, and now we see 1 or 2. So it's been really remarkable. Just some kind of complementary data from this area that was collected in 2014 is looking at insecticide resistance patterns in the 2 main vectors in these areas, and documenting high levels of pyrethroid resistance, a little bit of carbamate resistance, a little worrisome, at least for Gambia SS, and complete susceptibility to the organophosphates. So, kind of conclusions of this first project is that in Wallakuba, our low transmission peri-urban site, universal ITNs was associated with a significant decrease in malaria incidence, but not test positivity rate, and it doesn't appear to be a sustained effect. In the other 2 higher transmission sites, we saw no impact after the bednet distribution, but in Nagangara, when we added IRS with the carbamate, we saw a dramatic decrease in our clinical indicators of malaria. And then the second project I want to talk about is about resurgence of malaria following discontinuation of IRS in a previously high transmission site in Uganda. So this is so I mentioned there was 10 districts in the north where they sprayed for about 5 years, and in one of those districts, Apache, we had a health facility surveillance network there for quite some time. So we wanted to look at, we were able to look at the impact of kind of starting, continuing, and stopping IRS over this period of surveillance. And this is using individual level data collected from the outpatient department of a single health center in Apache, where the IRS was started in 2010. The first round was with a pyrethroid, but then they switched to carbamate and continued that every 6 months. All of the rounds of IRS, they documented over 90% coverage of households, and then they stopped the IRS in May of 2014, and the next months they gave out bed nets to the whole district. And we just looked at the temporal changes in the test positivity rates over time, and we divided it into 4 intervals: a baseline period before the IRS really became effective, and then during the initial period of effective IRS, a sustained period, and then a 4 to 8 month period after the IRS is discontinued. This is just some kind of the description of the patient population. We had over 120,000 patient visits included in this. Over half the patients are suspected of having malaria during this whole time period, and well over 95% of patients were tested for malaria that was suspected. Most of it microscopy, although later in the study they started using more RDTs. So these are the findings. So the black dots are the crude test positivity rates, and then the black line is the modeled, the kind of predicted test positivity rate from the time series analysis. And you can see that when we started in children under 5, about 80% of kids who had suspected malaria tested positive for malaria. So that's very high. It's hard to actually get that much higher because there are other things that cause fever in children. So after the first round of IRS with a pyrethroid here, we didn't really see any change, and then they implemented the carbamate, and we saw this rather dramatic decrease in the time series analysis, almost 6% absolute decrease in test positivity rate, and then they continued the IRS for 4 years, the carbamate for 4 years, and it got down to test positivity rates of less than 20%. It's pretty remarkable. Then they give out the bed nets, and within four months after stopping IRS, it goes right back up, and now it's at 80% again. And this trend's continued up until the current time. So really, just essentially, almost immediately goes right back to where it was. And then this is patients 5 years or older. The reason that I'm showing this is because actually in the period after stopping IRS, actually the test positivity rate has reached levels that in general, test positivity rates are lower in older patients because of immunity. But in this in this situation where they stopped IRS, actually we're seeing levels that are higher than we ever saw even before IRS, suggesting maybe there is some loss of immunity even in older patient populations. So in conclusion, sustained IRS, the carbamate achieved significant reductions in malaria morbidity in this area of very high transmission intensity. However, when IRS is discontinued, we saw this dramatic increase in malaria morbidity, and perhaps even above baseline in older patient populations. A successful ITN distribution campaign, at least defined as giving out the nets that you tried to give out, didn't really seem to have any impact on stopping the resurgence after IRS. And obviously this has a lot of implications for policy, including the other study is, IRS does, at least with the carbamate, appear to be effective in Uganda, but how long can you sustain it? How do you know when you can pull back? What other interventions may be necessary to either sustain the gains or drive it down even farther so you don't see this resurgence? These are areas that we're very actively interested in. But that kind of completes this story. Not necessarily a happy ending, but certainly is providing the government of Uganda with a lot of very useful practical data to try to think about what we do going forward. So I will take any questions. I don't know how I'm doing with time. I should probably mention that this is a tremendous amount of work and really done almost exclusively by Ugandans. We have 0 Americans that work in the field, and they're just really an amazing job, and some of our other collaborators.
Okay, thank you. I think we've got time for a few questions.
So that was really a nice talk. And I was wondering if you looked at the incidence of severe disease as well as the incidence of malaria.
Yeah, that's a great question. So we did, again, just because of time, I didn't include it, but we also had surveillance at a hospital, a Potch hospital in that same district. And what we documented was, in that hospital, we actually do blood smears on every single child that's admitted. We just found out that was more practical than, essentially everyone who's admitted to the hospital probably suspect malaria. And what we found was the same dramatic increase in parasite prevalence after they stopped IRS. In fact, there were 2 months where it was 100%, and this is over 400 children admitted, where it was every single child admitted for 2 months had a positive, test for malaria. Even, you can't be sure that it was causing their symptoms. But when we looked at the probability of if you had a positive blood slide, did you have criteria for severe malaria or complicated malaria? It was no different after the IRS was stopped. So again, we only have, and the same thing with the case fatality rate. It's actually quite low, and it's remained quite low. So at least up to 18 months of stopping IRS, we've seen no signal that malaria is more severe in young children.
And how about after application of residual how about after residual spraying? Because then you might think that they would have decreased immunity and actually may be more susceptible.
Yeah, so the inpatient surveillance was not started before IRS. So about halfway into the IRS program, that's when we started the inpatient surveillance. So all we have is baseline data during the final 2 to 3 years of IRS, and then we're looking at what happens after we stop it. So all we can say is we haven't seen, suddenly this dramatic increase. But the number of kids in the hospital with malaria is dramatically higher, obviously. They're just, if they have malaria, they're not necessarily more likely to have severe malaria.
Thank you. I have a couple of questions. First of all, do these models actually take into account net use? So you say the nets were distributed, but did you include in the model whether nets were actually being used?
Yeah, so that's a very good question. So in the cohorts, we give them a bed net when we enroll them, and every time we see them, which is once a month, we ask them if you're sleeping in your bed net, and 99% of the time they say yes. You know, so, but you know, maybe they're telling us what we want to hear. And if anyone ever, you know, loses their bed net or anything, we just give them another one. So we try to take that out of the equation. But again, we don't know for sure that they're using them properly because we don't go to their houses and observe them. So it's certainly a potential issue. And then in the community, all we can say is what the coverage levels are. We don't have any data from the surrounding community whether they're actually using the nets. So certainly one concern is and I think, you know, Don brought the same up in Malawi, is when you present this kind of, you know, somewhat depressing data that bed nets may not really be giving the bang for the buck that you thought it would, you know, one possibility is they're just not using them right, but we don't really know.
And then my other question was, you presented a bit about the insecticide resistance data from the vectors there, with Gambi SS showing potentially some development of carbamate resistance. But what is your species composition? Are the majority Arabiensis or Gambi?
So it's different at the 3 sites. So in Chihihi, near the border with the Congo, it's all Gambia SS, almost exclusively. And then in Wallakuba, this peri-urban site, it's predominantly Arabiensis. And then we also see some Gambia SS and very little Phonestis. And then in Ngagangara, we see all 3 of those species, but Gambia SS predominant, then Arabiensis, then Phonestis. Over the 5 years, we haven't seen a significant change in the vector composition, although it's pretty early after the IRS to know whether that's changing. We do see seasonal patterns, like Bill pointed out, where we see a lot more Phonestis in the dry season. At that one site, we see a lot of Phonestis.
Okay, yeah, my comment was going to be that that's probably something you need to keep an eye on, and also their behaviors. So if you've got maybe some area where you've got the IRS where they're showing some early indoor behavior, maybe that can explain why IRS is effective there compared to what we see in other sites around Africa where we're finding no impact of IRS on top of bed net use. Yeah. Well, thank you very much.